Today we have Dr. Mark Snowden, who has an MD and PhD.
You can use the mic, sure.
He's Associate Professor and Vice Chair for Clinical Services in the University of Washington School of Medicine, Department of Psychiatry and Behavioral Sciences. He received his Doctor of Medicine degree from the University of Washington, where he also completed psychiatric residency training and the Geriatric Psychiatry Fellowship. He worked as Robert Wood Johnson Clinical Scholar from 1994 to 1996, during which time he received the Master of Public Health degree from the University of Washington School of Public Health. He is Chief of Psychiatry of Harborview Medical Center, and provides and supervises geriatric psychiatry services to several community-based nursing homes and clinics. His research focuses on delivery of evidence-based mental health services to community-dwelling older adults and nursing home residents. He has also led several expert panels in the review of the literature and in formulating recommendations for the dissemination of evidence-based practices for depression and other mental health conditions. Dr. Snowden.
Thanks, Sherry. It's a pleasure to be here. Happy New Year's to everyone. Thank you. I hope my voice will hold up. I'm 3 weeks into this flu bug that is going around, and it was touch and go as to whether I was going to be able to do this talk 10 days ago, but I'm feeling better today, and I hope to be able to get through the full hour. So forgive me if I sound a little congested or if I have to break for frequent sips of water. It is a pleasure to be here, and as she was going over the bio, knowing that Margaret Kitchell walked in, don't hide. Margaret Kitchell supervised me back when I was a geriatric psychiatry fellow, so thanks for being here, Margaret. The talk today is about a specific program called PEARLS, which I will go over in more detail momentarily. By way of disclosure, there are no drug pharmacy conflicts of interest in the talk, but the funding that has supported a fair amount of this work comes from both the National Institute of Mental Health, the Robert Wood Johnson Foundation, a lot from the Centers for Disease Control and Prevention, the National Association of Chronic Disease Directors, and as you'll see, the Washington State Department of Social and Health Services. I want to make sure that I acknowledge the team that has worked with me on this. HPRC stands for the Health Promotion Research Center. It's a prevention research center that's funded through the Centers for Disease Control and Prevention to the University of Washington. It's one of about 30 some odd centers across the country. It's located up on 45th, not in the tower, but close to the tower. My 10-year research study coordinator is Leslie Steinman, and most of the work that I'm going to talk to you about today I have done side by side with her. There are several other people, some of whom you may know. Meg Christofalo has worked on other projects here at Harborview, primarily with Peter Royburn, and a whole host of others. The last line speaks to a number of people that worked at the Health Promotion Research Center that were actually the founders for the program that I'm going to talk about, PEARLS, and they include Cheryl Schwartz, Jim Lajerfo from the Department of Medicine, a former medical director here at Harborview, Paul Chanowski, who up until last summer was part of our department, Ed Wagner from Group Health, Barb Williams, who used to work at HPRC, and Eddie Edmondson. By way of overview, I want to give a couple of lines of work to give you some context. Part of it will be the Centers for Disease Control's interest in depression as a special interest topic, and then some work I did with the Institute of Medicine Committee on the Geriatric Mental Health Workforce. And they will hopefully give you a context for why I think this is relevant. By way of sort of disclosure, this is not going to be a talk about treatment per se. It's really going to be at a research on delivery, particularly dissemination and implementation. The way I think about it in relation to what I normally do, I'm in clinic on Tuesday mornings and in the nursing home on Wednesdays, and that's where I'm doing patient level work. A lot of my chief of service work is at an administrative level that really doesn't deal individually with patients, but with systems and programs and resources. And that's really the way I think of dissemination and implementation research. It's to say, once we've got something that we know works at an individual level, what does it really take to make sure that we can deliver that to the appropriate adopters and to make sure that it reaches the appropriate clients. I'm going to talk about PEARLS. I'm going to make sure you know what PEARLS is in terms of a key component standpoint, the evidence base that supports it, and then spend most of the time talking about the dissemination and implementation activities that we've been working on for a decade now. Centers for Disease Control. I gave a talk a few years ago and I asked the question, why would the Centers for Disease Control and Prevention care about depression? And for those of you who were here, I already gave you the answer, so I'm not going to pose the question to the audience again. But it wasn't what most people thought. Most people initially say it's because the CDC has been tracking suicide forever and they are very concerned about suicide. But that's not really what got them interested in this. What really got them interested in depression was their interest in health promotion and primarily exercise. And the more they looked at exercise, the more they saw exercise as a simple and yet robust activity that could address a number of health conditions. And what they found is that they were very limited in promoting exercise to the general population. And when they started talking to people in the field of exercise about why, the number one reason they gave was that people who are depressed don't want to exercise. And so at that point, the CDC said, well, if we really care about exercise as a general health promotion activity, we need to actually start doing something about depression. And at that point, the director of the Healthy Aging Program within the Centers for Disease Control actually got them to fund a multi-year project to help figure out what were interventions that were ready for community-based dissemination and implementation that would be effective treatments for depression. And we were able to secure that grant and did that work out of the Health Promotion Research Center. We had two tasks. The first was to identify what screening scales and instruments were appropriate, and then to identify effective interventions for addressing depression. We looked at depression from a number of different aspects because they were not DSM bound. The Centers for Disease Control knows about DSM, but they clearly recognize that there are other ways to think about depression. So we looked at both syndromal depression, what DSM would call major depression or dysthymia, but we also looked at things like bereavement, and we looked at subsyndromal categories. DSM-4 used to have a research criteria for minor depression. DSM-5 did away with that, I think, to avoid creating too many new conditions, and so now you would diagnose minor depression as someone who had 2 to 4 of the criteria symptoms, but not all 5 over a 2-week period. And you would simply call them depression, not otherwise specified. We clearly looked at other ways, including if you used any commonly accepted scale and you reached an appropriate cutoff. So the geriatric depression scale is something that is quite familiar to those of us in geriatric psychiatry. And so any of those types of categories were fair game for our systematic review. Community settings was the next challenge, and they were very specific about what they considered community. Senior centers counted, adult day health programs could count, home care programs, particularly those that are run by area agencies on aging, or AAAs as I will call them. Primary care clinics just made the cut because they felt most older adults would have access to a primary care provider. Community mental health centers would be appropriate. They specifically wanted us to exclude university-based research programs or university-based specialty care programs because they did not feel that your average older adult in the community really would have access to those types of programs. At the end of the day, we found 23 different types of interventions that we reviewed. We felt 12 of those types had adequate data for assessing whether they were effective or not. At the end of the day, the CDC was very interested in us presenting the top things from that review to the task force on the Community Guide for Preventive Services. This is not a CDC-sponsored group, but it is a national group that holds itself accountable for saying, what do we think works for communities? And so I went to Atlanta to present the data, and we had 3 things that we wanted them to think about. The first were home-based depression care management interventions. The second was clinic-based interventions, and we know a lot about that because that would include things like the impact model that Jürgen Unitzer developed here at the University of Washington and down at UCLA. And then we did comment on exercise. They did not give up on this notion of what does exercise do for people, and so we reviewed the literature on exercise for treatment of depression. What we recommended to the task force was that they would give a recommendation for home-based and clinic-based interventions, and they in fact did that. And so this screenshot is what you would see if you go to the website for the Community Guide, and they created a whole special section on older adults to highlight this work. When it came to exercise, what we said is even though there were a number of studies, there were such mixed results that we felt there was insufficient evidence to say that exercise programs really were an effective treatment for depression in older adults as delivered in community-based settings. It was quite an ordeal. When I was preparing for this, they said, think of it as defending a PhD dissertation. And I said, well, I've never had a PhD, so it doesn't mean anything to me. But having gone through medical training and residency, I suspect I will be able to manage it. And we were quite successful. What we were told is that no one had ever come to the group with 3 recommendations and had all 3 of them supported by the task force. So we felt very good about that work. So what is depression care management? How many people cook? This is the way I try to get at this. How many cooks are in the audience? All right, so if I said to you, there's a recipe, and it has a nut, an oil, an herb, and a cheese. What's that? Don't be shy. That's pesto. That's pesto. At its basic ingredients, that's pesto. You can interchange what the nut is. So some call for pine nuts, some call for walnuts. You can interchange the oil, you can interchange the herb, but it's at its essence, that's what a pesto is. So at its essence, what depression care management is are the following. It employs active screening for depression based on the notion that most people who are depressed don't come seeking treatment. So you actually have to, at a population level, actively screen for them. It employs a trained depression care manager that delivers an evidence-based intervention. Depending on your brand of the pesto, it might be problem-solving therapy, it might be interpersonal psychotherapy, it could be any number of things, but there has to be some evidence-based intervention being delivered. It involves education and self-management support for the client. It involves proactive outcome measurement and tracking, typically with a validated instrument. And it uses a team approach that has an ability to step up the level of care based on the outcomes for the client. And then it has active follow-up to make sure that people don't fall through the cracks. Okay? So PEARLS. PEARL stands for the Program to Encourage Active and Rewarding Lives for Seniors, and it's an example of one of those community-based depression care management programs. It was developed here at the University of Washington. The thought behind it was that older adults, particularly those who were socially isolated and had lots of medical comorbidity and physical impairment, were more likely to be depressed but would be less able to seek appropriate care for depression. And so the PEARLS randomized controlled trial study aimed to collaborate with an existing aging service agency, Aging and Disability Services here in King County, to determine the effectiveness of a home-based program for detecting and management of minor depression and dysthymia. It picked minor depression and dysthymia because it was felt those were the easiest for a non-clinical setting to manage. And the way to think about this is that it's very different than our clinic-based interventions. Most aging-related programs in the community don't have any clinical activity at all. And so starting with minor depression and dysthymia made a lot of sense because we don't believe that those require medications and medical evaluation to the same degree that major depression would. You'll see shortly that that became a problem for us, but this is where we started. Okay? So in its nutshell, we have problem-solving treatment. That's one of the evidence-based programs. We have social and physical activation combined with pleasant events. You can combine these last two circles into what many would call behavioral activation. So the evidence-based approaches here are behavioral activation and problem-solving treatment. We have active screening. The instrument that the agency now uses is the PHQ-2 and the PHQ-9. We take and find our trained depression care manager from the implementing agency. Unlike some programs that would say, well, gee, to do this program, you've got to actually hire a clinical person. The thought here was that most community-based agencies aren't going to want to do that. And so we wanted a program that would say, gee, if you've got hardworking, dedicated, interested people, we can develop an intervention that we can train them to do. You don't have to go out and hire somebody that's totally foreign to your organization. And that's what problem-solving therapy and behavioral activation really are. They're fairly simple to train even lay people to administer. We educate people with a depression fact sheet and with problem-solving therapy worksheets that they use every single time they have a session with the counselor. We monitor and track outcomes with the PHQ-9, and we have a team that includes both the client, the counselor, a supervisor, which is a psychiatrist, and then the primary care provider is involved when we need to administer antidepressants. Follow-up is done over the phone on a scheduled basis. PEARLS involves 8 home-based sessions. They taper from weekly to monthly, and so the whole program takes about 19 weeks to complete. The theory behind PST, or problem-solving treatment, is that if you are overwhelmed with unsolved problems, that will increase depression. And if we can teach you how to identify and solve problems in a systematic way, that will likely lower your burden of depression. We think it's patient-centered and directed because, unlike a lot of psychotherapies, the person that gets to decide what problems are worked on is the patient. It's not the counselor. The counselor may very well think they know what problems this person ought to work on, but they are specifically told to back off and let the patient identify what they really want to work on. And that becomes very important with older adults because one of their #1 fears when engaging in psychotherapy is some typically younger person coming in and telling them how to run their life. And that's not what they really want to do. Okay. We think it's skill building because if you can teach them the 7 basic steps, they can actually then use that skill after the treatment is over and done with. And we believe there's evidence to support that. Behavioral activation, again, includes increasing physical and social activities. And we start it wherever the patient is. And so we do this program with people that are homebound, some of whom are non-ambulatory, but we can still figure out ways to increase their physical activity as well as their social activity and pleasant events. Clinical supervision is a key component. I highlight it because it's probably the hardest part of the program for community-based organizations to get. This is where they actually are going to have to set up some relationship with a clinical supervisor for their care manager. Here, what we do is I have a contract with Aging and Disability Services to supervise all of the care managers that they have hired for the program. And they have a fee that they pay on a monthly basis for me to do that work. It's very similar to what we do in the BHIP and MHIP programs within the University of Washington. We can do this via conference calls and Skype, and so now I'm working with a care manager that's up in Edmonds, and she doesn't come all the way down here every time, and so we put her on the phone with us. People around the country can partner typically with universities, with psychiatry departments to find a psychiatrist who knows how to do this. We typically do more frequent sessions in the beginning to support the training. Again, we're working with people with no clinical background, and the training that we provide is pretty bare bones. And so in the beginning, while they're building their caseload, we use those sessions to reinforce what was done in the trainings. I like doing the supervision in groups because it does allow for peer learning. And so typically I can take anywhere from 4 to 5 counselors at a time. We go over all of their new cases. We go over any cases that are problems from either their perspective or my perspective in terms of following the PHQ-9 scores. And where time permits, we review success stories. This is what happens if you can put the program in place. This is the data from the original trial. The original trial had 138 people that were randomized to either usual care, which are the green bars, or the PEARLS intervention, which is the yellow bar. The instrument from the original trial was the Hopkins symptom checklist, the 20-item version, and we looked at how many people had at least a 50% drop in their score. And what you see is that 8% of usual care did versus 54% of the intervention group. We then looked at remission, and what you see is, again, a robust finding where the intervention has significantly higher numbers of people reaching remission compared to usual care. The outcomes assessment battery included a self-report item for were you hospitalized for any reason in the last 6 months. And what we found in that analysis was this very interesting trend where 34% of people in usual care had some type of hospitalization. Almost all of these are non-psychiatric hospitalizations, either medical or surgical, whereas only 22% of the intervention group reported a hospitalization. Both of these sets of bars were significant at the p less than 0.05 level, whereas this was at 0.08, so very close. We then looked at 12-month outcomes, and what you see is that now 12 months, which is approximately 7 months after the last in-home treatment session, you see similar results where people who were part of the intervention have higher rates of depression reduction and depression remission. And this is why we believe that something really did happen that taught them a skill that they were able to use once the intervention was over.
These people are still going to their community, seeing their health.
Right. Most of the people in this study were found in the home and community-based services program. And for folks who don't know, if you are disabled and homebound, then you get an assessment, and that assessment determines what types of services can be brought to your home most often. So chore services, you might be put in a visiting nurse program. So that's the level of illness that most of these people are at. Most of these people were not, in fact, at senior centers. I'm going to show you some of those results momentarily.
And they had dysthymia, not?
Had minor depression or dysthymia. The vast majority had minor depression. Yes?
Can you get a count on how many sessions out of 19 they actually did?
So the program calls for 8 sessions over 19 weeks, and the mode was 6. So most people got 6 sessions, not the full 8.
What about the other group? Any home visits at all?
They had no home visits from a counselor. On average, these patients get seen by their case manager, who works for Aging and Disability Services to make sure that they're getting what they need. On average, they get seen twice a year.
So do the yellow bars, do they get ongoing treatment as usual twice a year plus the
Exactly. Yeah, so 6 visits on average. Okay. All right. So next line of contextual thinking. I had the pleasure and honor to be selected to serve on an Institute of Medicine task force committee on the mental health workforce for geriatric populations. This was a congressionally funded and mandated committee. It was concerned about this growing population of older adults with a burden of mental illness and trying to figure out, was the country at all prepared to deliver the services that we needed. It was chaired by Dan Blazer, and for those familiar with geriatric psychiatry, he literally wrote the first textbook on geriatric psychiatry and does a lot of work around the epidemiology of depression in older adults. Steve Bartels from New Hampshire was on this group, and Steve's been out to Washington to speak several times. Fred Lowe was a person from the VA system. It was really a who's who, in my opinion, of health services researchers, and I was quite honored to be a part of the group. The key findings from the group, we did a lot of reviewing of the literature. We had interview days with almost anybody that wanted to come and testify before the committee in DC. And for those who don't know, about 1 in 5 older adults has some type of mental health or substance use problem. And for contextual factors, that's 8 million people. 2 million of those, we believe, have a severe mental illness on the frame of schizophrenia or bipolar disorder. Through data that Fred Blow was able to get for us from the VA system, it's very clear that older veterans have numbers that are even higher than that. What we concluded is that the workforce is not prepared in either numbers, knowledge, or skills to care for the mental health and substance use needs of a rapidly aging and diverse population. We looked at clinical and educational certification programs and found that those were going to be insufficient as well. To give you an example, and this is a slide that was in the book report, it tracks the number of people going into geriatric medicine and geriatric psychiatry. So the blue bars are geriatric fellowship spots in medicine. So in 2001, 2002, there were 500 spots for fellowships, and about 250 of those were filled. If you look at the geriatric psychiatry, the numbers are much lower, but you see this very steady but slow decrease. So as I get older and approach retirement the way Margaret is, there will be fewer and fewer geriatric psychiatrists. Our program is in this group, and for those who have tracked it, we too have experienced this. Last year we went through one of our first episodes of not having fellows in our program. And so this is a real problem. What the committee did, though, for the first time that I think anyone can remember is to say the answer to this is not more incentives for fellowships and specialty trainings, that we've been doing that for decades and it really has not worked. The answer to this is to have a new paradigm for thinking about things. And so what they said is, let's look to see what research models would suggest you could do to have an adequately prepared workforce, both in terms of numbers and skills. It redefines the role of the specialist, a person like me or Margaret, from somebody who's going to be there to treat patients to do something different. And that's exactly where depression care management comes to fore. My role in the depression care management team is not to see patients, it's to supervise care managers and to help them see patients. We're expanding the workforce not by trying to create more geriatric fellows, but saying, gee, can we take people that work in community-based organizations and train them to deliver an intervention to people that need it? And so it's a very different way of thinking of how to solve this problem. And I actually give the committee a lot of credit for stepping out and saying we needed to do something different. Okay? So where does that mean we were in 2007? So 2007 is 3 years after the JAMA publication that Paul Janowski wrote on the original Pearls trial. And what I can tell you is this is when I entered the picture. There were 2 programs in the country offering Pearls. One was here in Seattle and one was in Vermont. The program in Vermont was funded through a United Way grant, and that was it. The program here had treated probably fewer than 100 people over the 3 years since the original study. So it was very clear that, yeah, the evidence is out there. This is a very nice publication, but it seemed to be going the way of a lot of research where we get a very nice publication in a very prestigious journal, but it really doesn't have legs to actually live on beyond that. Another way to think about it is in 2007, the Health Promotion Research Center did submit Pearls to be considered for the SAMHSA National Registry for Evidence-Based Programs and Practices, called NREPP. What's nice about that is that it convenes an independent group of experts outside of SAMHSA who grade your program on 2 dimensions. The first is, what's the quality of your research? And the second is your program dissemination ready? So what you see is, for quality of research, they look at things like the reliability and validity of the measures that you use. Can your intervention be delivered with fidelity? How much missing data did you have? How carefully done were your analysis? Did you look for confounders to make sure that the end results were really due to your program? And on that 0 to 4 scale, Pearls in 2007 got a very good rating of 3.6. What was not so good was the dissemination readiness. For dissemination readiness, it asked things like, do you have implementation materials that can be readily disseminated? Do you have the ability to train and support and provide resources for people wanting to adopt your practice? Are there any quality assurance procedures in place to assure fidelity and the management of risk? And for that, Pearls got a 1.8 on this scale. And so it was very clear there's a lot of work to be done to get this program to the point where it could be more easily and readily disseminated. That leads to the question of, well, how would you know when you've effectively disseminated or translated a program? And it seems like a pretty simple question, but there's actually a fair amount of debate about how you get at this. And the person that I think has spoken the most clearly on this is Russell Glasgow, who was in Colorado, and then he was with the Cancer Foundation. And he created this thing called REAIM. And REAIM is an acronym that stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And what he says is, you will know you have done this well when your program reaches the people that it's intended for, it remains effective, it's been adopted by the people that you would want to adopt it, it can be implemented with reasonable fidelity, and it can be maintained over time. So, to me, pretty straightforward. Anytime, in my view, you're researching in one of these outcomes, you're doing translational research. What he didn't do was to tell you how to get there. These tell you your end goals, but they don't say how to get from point A to point B. And there are lots of models. The Health Promotion Research Center has a model that I'm showing you here. I think Jürgen did a talk 4 years or so ago, and he showed that there's dozens of these now. And the reason there's dozens is that nobody really knows exactly what works. So this is a somewhat complicated figure, but I'll walk you through it. What it says is that you have evidence for something that comes from an intervention that used some type of resource. And in our case, we had a Health Promotion Research Center that partnered with Aging and Disability Services to produce Pearls. And at some point, you were then trying to get that program over to some other place that doesn't have it. So that's your next community-based provider. And they have to have done certain things to be ready, and then they've got to adopt the program, and then they've got to implement it, and they've got to maintain it, and then they've got to get the outcomes that they care about. And all of that work takes place in an environment that's driven by social marketing principles in the HPRC framework. It happens through innovative design where we then change the program, or through a dissemination strategy that says, gee, we can change something about this provider. So I did this talk in San Antonio a few years ago, and we had a commentator, Martha Bruce from Cornell, come up, and she put all of this in a very simple way that I actually like to this day. And so what she says is that there are 2 tasks at hand. One, you have to figure out how to modify your intervention to make it acceptable to community providers. And you've got to figure out how those community providers have to modify what they do to be able to receive and use your implementation program. And it's really that simple. And you can put all this other stuff around it, but at the end of the day, those are the 2 types of change processes that are going on. And that's what these arrows in the middle really reflect, that there's change going in both directions. Okay? So our approach was, okay, if we build it, they will come. All right? And that comes from a movie that I think most of you will have heard about, Field of Dreams. Okay? So, Centers for Disease Control said, we will help you build it. They funded a national conference that was held in Atlanta, featuring several types of community-based treatments. Pearls was one of them. They produced very slick, impressive program briefs and policy guides so that anybody wanting to pick this up would have materials that they could use. And they even offered technical assistance scholarships for people who came to the conference who wanted to apply to implement the program and receive our assistance. Washington State got interested for reasons that I'm going to show you momentarily, and they said, okay, we will help you build a toolkit. So you will have implementation materials to give. We will train 2 people from every area agency on aging in the state, and there are 13. And so they said, all right, we will fund the training so they can come to Seattle and learn how to do pearls. And then most significantly, they went to work to get a revision of the Medicaid waiver that Washington State uses so that pearls could be covered as a Medicare delivered service. Okay. Now, why did they get interested? The first reason goes back to that slide that I showed you about outcomes. And they looked at that outcome around hospitalizations and they said, gee, if this really does reduce all-cause hospitalization, it will probably save the state money to do this. We actually did not have a formal cost-effectiveness study, but that data alone impressed them. And so they said, we want to now hire you to figure out how big of a problem is this within the Aging and Disability Services Administration older adult population. And so we looked at 2005 data that they had from a depression instrument called the Centers for Epidemiological Studies Depression Scale. And they have been collecting that routinely as part of every single home and community-based assessment. And the scale can be broken down into 3 groups. If you're over 10, you probably have major depression, and that's what it was designed to pick up. If you have less than 6, you probably don't have even minor depression. And if you're in this 6 to 10 score, you probably have minor depression or maybe dysthymia. And so what you see when you add up the numbers is that well over 50% have some significant type of depression. And they said, okay, now we're convinced we need to do something. And therefore, the training was put in place and the toolkit was developed. We then had to deal with some realities about costs, and they actually taught me that the way costs were reported in that nice JAMA publication are not the way programs think about costs. The JAMA publication talked about what's the cost per client that got treated, and that cost was $630. What it failed to account for was that most programs don't just get to pick the people who get treated. You have to screen a lot of people, and many of those people don't want your treatment, but you still spend time, energy, and money doing that work. And so when you actually start to figure in what does it cost from the program perspective, it actually is about double that. And we did analyses with Aging and Disability Services that showed that it's about $1,350. Okay? They said, all right, that's not a deal breaker, and they went to Medicaid and they said, all right, we were going to fund this program at 8 sessions plus an engagement session to cover the cost. So if you multiply 9 times 150, you get to the $1,350. So this is covering costs. It's not making money, but it's assuring that if you decide you're a AAA and you want to do this, that you're not likely going to lose money on the program. We then said we got to ramp up trainings. If the state is prepared to train people, we hadn't trained anybody in Pearl since the original trial. And so now we've got to figure out a way to train on a regular basis. And so we put together a training program that Paul Chanowski was actually very instrumental in developing. We're now at a point where we're putting some of those modules online so that people don't have to come here to Seattle to be trained. If you have a big enough group, we can actually take the training to you at your location. As I mentioned, we developed a toolkit. It's free of charge. It's on our website. It has all the forms and materials that you would need to actually get the program up and running. And we then decided to start providing regular technical assistance. Because there were people funded for a technical assistance scholarship, we created monthly calls with anybody that had been trained to discuss with them whatever challenges around implementation they were experiencing. And I continue to do those calls once a month with Leslie Steinman. At that point, we applied for a translational research grant that was an R18, and it allowed us to do a few other things that I'm going to very quickly tell you about. We ran some focus groups that Meg Christofoulou ran to figure out what were the problems that agencies were having. We developed a fidelity instrument so we could figure out how were people changing the program, and then we developed an intervention called implementation coaching. we did a hard to reach study to say, okay, you have a program here in Seattle, who are the hardest people for you to reach that you would like to reach? And the list came pretty easily. Veterans, because the levy that funded the programs in Seattle specifically wanted veterans treated, and veterans were a very hard to reach group. African American men and women were hard to reach. Filipino men in particular were hard to reach, along with other racial and ethnic minorities. They said that we can reach younger old people pretty well, but the older old people, people 75 and over, are a bit harder for us to engage. There were actually rural parts of King County, and that was a real challenge for our care managers. And then people who had limited education. And this was an issue because a lot of the materials are written. And so if you don't read and write English pretty well, doing problem-solving treatment with a worksheet becomes a real challenge for you. We published this work with Leslie as the first author and the gerontologist. We had a second qualitative study that looked at people from the agency, former participants, and focus groups, and it focused on what are your recruitment barriers. And the quote that I loved the most was from a case manager who said, it seemed that there was more screening out than screening in. And what they meant was there were too many exclusion criteria. And so the question is, where do the exclusion criteria come from? Things like language. You had to speak English. You had to have the right type of depression. You had to be the right age. You couldn't have a history of other psychiatric problems. You couldn't have active substance abuse. You couldn't have cognitive impairment. Where do these come from? Anybody know? Yeah, it came from the trial. So you take a community-based agency that looks at a JAMA publication and says, okay, we want to do that. And if in your JAMA publication you excluded all these groups, they say, well, we probably have to exclude them too. And so we were the ones who actually did this. It wasn't their idea to exclude these people. This actually came from the original trial. And so we had to systematically now undo what had been done in the effectiveness trial. We took on interpreters. We said, okay, how do you do your other work that's not depression-based with people that don't speak English? And their answer was, we use an interpreter and we take the interpreter to the home. And so we said, all right, we can do PEARLS that way. And we did. I trained Leslie to be a PEARLS counselor. It turns out that the two most common languages that are non-English speaking clients have that are older adults are Russian and Somali. And so we said, we'll take those two groups, and it's nice because they are very different populations. And we found that we had a 78% response rate, meaning this drop of at least 50% in their PHQ-9 scores. And this is identical to what happens to the English-speaking clients. And so we were very impressed, and it was not different between these two groups. It was the same for the Russian clients and the Somali clients. And so we said, okay, we now got that one done. Yes?
With interpretation, my experience is that can be very challenging because of the opposite sides of the community, so that people know each other. And did you run into any challenges around that?
We did. We tended to want to use, once we found an interpreter that was acceptable to the client, we kept the same person so that we weren't switching.
Client thing.
Yeah, we had to get a good fit, and then we tried to schedule things so that we could keep the same interpreter throughout the treatment sessions. Okay. We then took on what happens if you're too depressed, and that really means that we were excluding people with major depression. And we knew that we could treat people with major depression, if we could figure out a way to bring medications into the program. And so Paul did a very nice study where we got funding through the CDC because they wanted to look at epilepsy. And he said, gee, epilepsy has a lot of people with major depression, so let's try PEARLS with them. And lo and behold, what you see is that it will work. So the red bars are the people with usual care, and the blue bars are the people with epilepsy and major depression who got PEARLS, and they had very nice improvements that went all the way out to 18 months. So now this is a year past the last in-home session. Okay. So now we call it PEARLS, but we dropped the seniors. It's now just programmed to encourage active and rewarding lives, because in addition to major depressives, Paul treated anybody that was 18 and over. And so we got out of this. This is only a program for older adults. Okay. The fidelity instrument was used to figure out what are people needing to do differently, and we administered it to 59 counselors spread across the country. And what we found is that there are a few things that people had to drop from the original trial. The way we assess counselor competency. In the original trial, you had to produce an audio tape that an expert, Karen Smaling, who was in the department back then, would listen to and to determine were you delivering problem-solving therapy at a high enough level. Most programs can't do that. Most programs now use clinical supervision as their way to figure out, is this counselor doing what we really want them to do? The frequency of clinical supervision changed. In the original trial, it was once a week, and most programs can't afford a psychiatrist once a week. So most of them now do it twice a month. If they have a very small program, they may only do it once a month. On average, here in Seattle, because I supervise all of the counselors here, we review every client at least 4 times in the course of their treatment. So even though we're only doing supervision twice a month, it's not that clients aren't getting presented to me for supervision. The other thing we notice is that we don't educate people just with written materials anymore. We have to do a lot of stuff verbally to deal with people who have limited reading and writing skills. And clearly most programs, once the data came out that you could do this with people that were younger, have dropped their age to at least 50. Implementation coaching, we tried, and this is a slide that really brings home a message that's not so good. What you see is that we had a baseline rate of about 10% of people who were eligible got referred, and about 4% actually enrolled in the program. And we were convinced that if we worked actively with the agency to do all types of things with them, that we could bump this up. And at the end of the day, even though it was a much longer period of time, so we have many more eligibles, the percent who enrolled really is unchanged. And this is disheartening. For those of you who were here, you could see that in the original trial we had 36%. This is a different group. This is the difference, in my opinion, between doing population-based work and doing work with what might be considered the ready or the early adopters. Most studies don't get their patients through universal screening. Most studies get their patients because somebody refers them. If you want to know why this is so relevant, we have the same issue now in BHIP. And I have data that Jürgen and I have been looking at that would say that if you look at all the primary care clinics that have BHIP in them, we treat about 10% of the people that actually have a problem. And if you got the email today, you know that the University of Washington, as an accountable care network, now has about 10,000 Boeing employees who are signed up with us. And we are responsible for universal screening and universal treatment of depression with them. And so there are big dollars going to be at stake about how well we will solve this problem around, can you actually reach the people that you need to reach, even if you put in place the program that you think will be effective. Okay. Today, the map looks a lot better. Pearls exist in 50 sites that are spread over 18 states. We've probably treated over 2,000 clients. And I am impressed by this. This is a lot of hard work, but that previous slide still gives me pause to say that we've got a lot more work to do to actually reach the number of people that we would want to reach. How is it funded? There are many ways to fund it. The biggest advance we've had has been this Medicaid waiver. We are trying to get more state units on aging to support getting a Medicaid waiver in their state, because there's no reason other states can't do the same thing that Washington has done. This is a timeline that just reviews what I've shown you. The blue line shows all of the training activities. The green line shows our dissemination and implementation work, and the orange bars are the 2 major effectiveness trials. With that, I will show you our updated SAMHSA registry. In 2014, we reapplied, and what we got was a 3.5 for our quality of research, but now we are at the full 4.0 for dissemination readiness. Now, it's clear that being ready is not the same thing as being disseminated, but at least I think we are moving in the right direction. In addition to SAMHSA, we've been recognized by the Agency for Health Research and Quality on their exchange. And then in 2011, we received the Archstone Award for Excellence in Program Innovation. This is our list of partners, and with that, I'll stop and take any questions people have. Yes, Margaret.
How about international?
Ah.
This would go the third world condition.
Yeah, Richard is doing a lot of this work along with Jürgen. They're tough challenges, and so I think we're looking at depression, but they're also trying to figure out ways to treat more severe and persistent mental illnesses at the international level as well. Yes? You can refer through Senior Information Services now. You can refer through ADS. So we've opened the doors because there are more providers now outside of ADS. There are many more avenues for referral. So Senior Services still is probably the central point for referral. Yes, Chris.
Once you got your product disseminatable, then you wind up with a 4 to 5% reach. Was it still the case that, like the case manager said, that more people were screening out than screening in, or were they screening in and then refusing?
The refusal rate is about 30%. So I think what they would say is the hit rate for a referral went up. There's still a lot of people who don't engage, but it's not because we're simply excluding them anymore.
If you estimate that your denominator was that, and then you only delivered the package to 4%, are you estimating that your denominator estimated positive screen, or estimated everyone?
The denominator are screened positive. So I think what you're missing is not everybody gets referred. There are a lot of care managers who come into the home, they do the assessment, they get the depression scale score, but instead of referring to Pearls, they say, oh, you told me you're taking an antidepressant from your primary care provider, that's good enough, I'll move to problem Y. So, so it's not that everybody is getting referred. It's very hard to explain to them that that's what we compared this to. All those people who were being treated by their primary care providers inadequately. But in many case managers' minds, if that's what the client says they're doing, they move on to another problem that they've got to address, and they don't make a referral to Pearls. We would love to create better incentives or disincentives for referral, and that's a very difficult thing in an agency that really doesn't have treatment of depression as its primary objective. They've got a lot of stuff that they do, and so they've stopped short of saying we're going to mandate that everybody refer to Pearls when someone is
I was
depressed.
thinking of the screeners as Pearls agents, but Pearls is waiting to be referred to.
Exactly.
By the TAU.
That's right. That's right. Chris?
You mentioned about Medicaid waiver. Do people on Medicare get any coverage for this, or is there any way that potentially you get Medicare to cover this?
We haven't talked about it with Pearls. Jürgen has done a lot of work to try to figure out, can you create Medicare reimbursement for care management at the clinic level for major depressives, but it hasn't reached this for Medicaid. Anybody else?
Well, even when we get referrals from primary care, it's the provider referring them, and it doesn't mean that the patient wants services.
That's right. That's right. This problem, the reason I showed that stuff about BHIP is this is not unique to Pearls. If you look at almost anything we do, if you could really get yourself to what's the denominator of people that need the service, you will see that there's a huge gap between those who get treated and those who need treatment. And that's why I think we have to keep working at this, because what you do, Chris, on the addiction intervention services, it's the same thing. I mean, you reach a small percent of people who are eligible, who need the service. BHIP would be the same way. Specialty mental health care would be the same way. So this is not unique to Pearls. Great. Thank you very much.
Thank you.